My second differential would be is patient suffering from decay, diabetic ketoacidosis.
Yes.
Since the patient is recently diagnosed diabetic
Metabolic.
and metabolic cause of this junctional rhythm, I suppose.
Yes.
And since the patient was put on Telma H, there is also a possibility of hyperkalemia in this patient. And since there is altered sensorium
so one might be due to dyselectrolytemia, another is due to the metabolic cause. That you are telling.
Yes.
There are two important headings.
Since the patient was having recurrent loss of consciousness, patient was shifted to ICCU and treated with moist O2 inhalation, and broad spectrum antibiotic was given and IV fluid was started. And since the patient was recurrent having cardiac syncope, the temporary pacing was done. It was done through the right femoral vein, and the lead is placed in the RV apex, and RV pacing was done, and it was rate was maintained around 60 per minute. Then the meanwhile the reports were found to be hyponatremic. Then the patient was put on 3% NaCl over which was given over 6 hours thrice a day, and hyperkalemia treatment we'll discuss later. With injection calcium gluconate was given, insulin drip, salbutamol nebulization, K-band sulfate. Then the progress of this patient was day 1 the rhythm was dependent on pacing with the rate of 60 per minute, and potassium was 6.8, sodium was 103, and protocolon was 13,800, and BSL is 383 on day 1. On day 2 the potassium decreased to 6.1 with the treatment, and still patient was dependent on pacing. On the third day, patient began his own sinus rhythm at 72 to 80 per minute, with potassium levels coming to almost normal, 5.6, and sodium also recovering. And the total count came to around 11,700. The creatinine levels also decreased with the treatment.
BSL is a recognized term. BSL, is it written in the book, BSL? So why we are using this term, BSL?
Yes.
We cannot use like
yes.
RBS, okay, you can use. But why it is BSL? Nobody can understand.
And the final diagnosis is sepsis with hyperkalemia, with hyponatremia, with ARF, with junctional rhythm, with diabetes, with hypertension. So now coming to hyponatremia, hyponatremia is defined.
No, before that you go back. You write about here you summarize about the detail of the patient. Before going to management of individual things, you just summarize the case for the audience. Yes.
The patient was presented with altered sensorium and loss of consciousness
yes.
2 times, and vomiting and mild fever since 3 to 4 days, without any with recent history of diabetes and hypertension, without any history of chest pain, palpitation, shortness of breath, or any limb weakness. On examination, patient was found to have bradycardia with disorientation without any significant neurological finding. On investigation, patient was found to be hyperkalemic, hyponatremic with sepsis. Patient treated accordingly, and patient recovered after the treatment.
Good morning, sir. Happy New Year to all. Basically, this patient is a very interesting step. We have received, Dr. Patros sir is there, he was in evening round at around 6:45. And one patient has, when he was in casualty, one patient had all of the history of collapse in that time. And he also saw the pulse, it was not palpable, and patient was on this. Dr. Swati, our casualty officer, was there. Both of them alerted the situation, it was almost collapse, and after giving atropine, again regain. One lady, elderly lady, around 65-year woman. Immediately we were in hospital. In that time I was taking classes of DNP in upstairs, and that time when immediately 5 minutes after we saw it, the pulse was coming and going, and the patient was having typical Stokes syndrome. And after then again regain somewhat imbalance. Immediately we have taken up the case in ICU, and without losing the time we did the TPI, temporary pacing, to save the life first. Then the whole pictures came after the report. The report was very surprising. The sugar was 450 plus, the sodium was 102, the potassium was 6.8. So three major problems with unconsciousness. So after around 2 hours of pacing, somewhat patients regain the stabilize these things, and then the sugar, we have now started thought the rhythm was typically junctional, somewhat asystolic to junctional it was going. So around, and he was basically the patient was sister of our colleague Mr. Haldar Babuji, those who retired from his own sister. So both of them we have taken a high risk consent, we did it. Now whole thing is that hyperkalemia, hyponatremia and diabetes. We sent the blood for urine for this. It was ketonemia also. There was recurrent vomiting. 2-3 times there was syncope in day. So the whole complicated case in all that. Then we have started one by one. Number one, we stabilized the rhythm. Number two, we started with the treatment of the hyperkalemia. So regarding hyperkalemia, from gluconate to insulin drip, and giving the saline support with for the hyperglycemia, and gradually treated with a 3% NS at least 3 times. Accordingly, serially, parents have shown that how we achieve for 3 to 4 days. Second days, it came to stabilize, but initially urine was less, anuria, early the oliguria, and after 2 to 3 days of stabilization, the urine has again gone in 6 liters. So it was a polyuric phase. And then after this whole treatment, patient is stabilized and absolutely no damage. It was an acute phase. So all the 3 correction has occurred and rhythm was normal, and finally patients have no damage in kidney and heart was normal. Rhythm came to stabilize. Since rhythm is back, no need for permanent pacing because it was a metabolic side. There are a lot of rhythm problem. So absolutely step may last after 2 weeks of hospitalization we discharge us. So this case have a multiple problem in all the 5, 6. Very rarely we are getting all the 4, 5 problems in a single patient. And finally, we achieve this thing, and target is all the rhythm is kept. So this is the message. That's why we have brought this patient, that all the 4, 5 metabolic condition and control. Now, what was the risk factor here in this patient? The risk factor we thought here was in private treatment part, particularly losartan age, and sometimes diabetes is a major cause for the this metabolic imbalance, and there was a sepsis underlying, recurrent vomiting was going on, and recently diagnosed as a diabetes. Earlier she was absolutely all right. So these are the might be the first episode. Rhythm's problem is temporarily, so that's why no need for the PMI. Now regarding this case, any query from anyone regarding this patient?
The patient was on losartan age, losartan ARV. Naturally, it will increase the hyperkalemia. Okay. Thiazide diuretic, it will reduce. So how the losartan age will be blamed?
No, not only because
But then I'm asking,
patient
losartan
is having-
age, if it is there, then hyperkalemia on one side and hypokalemia, so it should be balanced.
Yes.
Basically, it was a first time diagnosed as a sepsis.
But it might be due to
In,
sepsis.
plus, in a case of recently diabetes, first episode, plus recurrent vomiting, addition losartan X was continuing. So pre-renal azotemia was one part, and followed by, because pre-renal stage also we have gone, first day annurization, second day, third day, 6 liters of urine. So we have tried to balance it. Plus
So
the
hyperkalemia most probably due to sepsis and
But
ARA.
it is maybe associated with the
pre-renal.
Most probably ARA
But pre-renal
most probably,
stage.
most probably.
And followed by, because I have gone through all the three, anuric phase, oliguric phase, anuric phase, recovery phase. All the three phases I have seen. And the challenge was ketonemia. Again, what was the cause of ketonemia? Here the ketonemia might be prolonged vomiting, or we are early decay, we are getting the patient in early decay. So the challenge was the saline. How to put a saline? We have given 3 to 4 liter saline with intermittently with insulin and through thorough every 6 hourly monitoring, and the fluid balance has been covered. Because ideally if we receive decay, which incidence in now is declining, and particularly in type 2 diabetes decay is less. So here we have thought that ketonemia, because second day onward ketonemia was not present. So again here it is this. Now the Stokes Adam, rightly he has Mahesh, if you will not present regularly, this will be a problem. He has written Stokes Adam as a symptom. It is absolutely wrong. Stokes Adam will be never a patient's complaint. It is a medical diagnosis. Mr. Stokes and Mr. Adams have described one syndrome. Whenever there is just loss of consciousness and regain within seconds, and due to cardiac cause, was labeled as a Stokes-Adams syndrome. So SAS, it is a normal, our customary to take word on writing no SAS. Doesn't mean that where you write. It is absolutely wrong terms by the in presenting complaints. Stokes-Adams is very common. Throughout the syncope, our hospitalization, about 30%, 20% patients, if we carried a research on our hospitalization symptom, syncope is around 20 to 25% patient may present with syncope. So what is the syncope? Syncope is the lack of cerebral perfusion due to sudden either cardiac, neurological or both. So most common syncope cause throughout the world is the vasovagal, VVS, vasovagal syncope. Very commonly, patient is drawing a blood, all of a sudden fell down. Patient is sitting in front of a parrot ground 2 hours, 1 hour, standing in his position, suddenly venous pulling and leading to the collapse of the patient, very commonly. Similarly, any frightened situations, by hearing the death news, patient will suddenly. The treatment of vasovagal is very simple. Just hold in a straight line, that their flow will come. Hold up the limbs to it, so that immediately patient will regain. Again, vasovagal syncope will regain within the seconds, within minutes. If someone is not regaining in minutes, it is not vasovagal. Always it is the vagotonia or pulling up will lead to this. Second common syncope after this is the neurological syncope. Whenever there is a cause, or some is the cardio-neurological syncope and cardiac syncope. Cardiac syncope most commonly heart block, rhythms, various variety of sudden or other VT, VF, this is the syncope. And neurological, even seizure is a subset of the syncope. And if there is a neurological syncope, the regain will be 2 to 5 minutes minimum, never in the immediately. So whenever there is a seizure, the history will be more than 2 minutes regain. If someone is regaining, एक झटका लगा हमको फिर आँख खुल गई. So this is a very typical of either vasovagal or cardiac syncope within seconds. So we are keeping the loss of consciousness with the duration of the how much second patient is regaining is very much clue that what is the pinpoint diagnosis for the syncope. And syncope is the most common symptom. Everyone in this house have in life 1 year 2 times will have experience of syncope. Sometimes vomiting, आँख के आगे अंधेरा छा जाता है. All of a sudden, it's a part of syncope. So this is the way to approach. Second most common in our hospital, and is the problem we are facing the hyperkalemia. Hyperkalemia throughout the worldwide, hyperkalemia incidence is now increasing because two causes. Number one, diabetes is increasing, and diabetes leading to end organ damage, particularly nephropathy, and it is the permanent cause of the problem in hospitalization in hyperkalemia. And hyperkalemia is a major killer disease. And second is the medication. Most of the diuretics with communication. So two causes for hyperkalemia. One is the CRF, particularly leading to the diabetes. Second is that.
Which is the safest then antidiuretic for hypertension you can use in the OPD?
It depends on the like calcium channel blocker do not cause use. ARVs should never use in the hyperkalemia. So there are a separate group. We have to individualize the patient, look for all the findings, and then decide which is the suit. There is not rule of thumb. We have to take the history, do the examination, see all the target organs, and then decide which antihypertension will suit to each patient. And regarding hyperkalemia management, there are very typical management style is there. First, we have to give the gluconate to counter the physiological changes in the heart, because heart stop in the diastole in hyperkalemia. If we take a death from diastole and pre-death of X-ray and post-death of X-ray, there will be the hyperkalemic heart suddenly stop in diastole. So it is a feature that once heart is contracting, hyperkalemia will not able to patient will not able to contract. So our first treatment, we have to physiological antagonism of the potassium. So we used to push the gluconate so that calcium is a contractor of the muscle of the ear. And second is the treatment for hyperkalemia for all the 4-5 treatment, particularly like insulin, glucose drip, bicarbonate as per pH, and according to the insulin and other treatment should be given. Salbutamol is now trend in the treatment of this, because most of the potassium remains in the intracellular, and when there is a salbutamol beta 2 agonist, it shifted the potassium. So that's why it is being used as a hypokalemic agent for the beta 2. So this way we are treating the hyperkalemia. And finally dialysis, if it is remains. Dialysis is the one modality to reduce the hyperkalemia. And
Salbutamol as inhaler or
inhaler. It is all as an inhaler. Even
is not required. Tablet is not required for this.
No, tablet is not, because sir, inhaler as it is a modality is for its side effect is hypokalemia. So its side effect is used as a now routine therapy for hypokalemia. And second important this case is hyponatremia. Here again hyponatremia is coming. And one more point for hyperkalemia, there is pseudo hyperkalemia, and this is also in hospital setup, laboratory setup. Dr. Mahamaya is there or not? Pseudo hyperkalemia is a very much reported, because when we are taking more thin needle for drawing the blood, it will lyse the RBC and leading to the raise in the potassium content. So this is known as iatrogenic pseudo hyperkalemia in hospital setup. Suppose we are keeping all this and pushing in the channel for blood container, so that will lead to the change in this. Similarly in hyponatremia, when there is a drip arm, one drip is going on the same arm, they are collecting the blood, that is lead to the dilutional this hyponatremia. So hyponatremia cause in hospital setup, when there is no other cause, no clinical evidence for hyponatremia, again we are getting hyponatremia. Sometimes these two cause has been highlighted in hospital setup for hyperkalemia and hyponatremia. So and lysed blood is the cause for hyponatremia. But regarding the treatment for this last problem I will discuss, hyponatremia. Again, hyponatremia is a very challenging case, and it is quite common because now geriatric population is increasing. This electrolyte in our hospital, you've done the survey, we are facing huge, our requirement for 3% NS. Last 10 years I am seeing it is going in big way. It's required because so many patients we are getting hyponatremia. Most of them are the geriatric patients, and because hyponatremia again cause is depend on the etiology, what etiology is coming. And treatment started from, we have below 100 generally non-compatible, but we have got some 95, 92 also which survive. And up to 100 to 120, this is the margin. Around 100 to 110 is the most unsafe margin. 110 to 120 is the safe margin. Above 120 is the tolerable. Now the one there is a 100 to 120. How to correct this generally is depending on, there is a so many formulas to calculate how much will be depend for that. We have seen. You want to tell, just you go on. So just we quickly 2-3 minutes we will summarize this all, because this is a major problem. That's why we selected that hyponatremia, hyperkalemia, hyperglycemia, rhythm problem. All these things may contribute.
The